This is Carol from the Society of Thoracic Surgeons. This is the adult cardiac user group call for April 15th. We're going to get started here. On the phone with me, I have our Iqbia team. Melanie Vend will be giving us an Iqbia update, and then I have some other updates to go over with you just before we get to Melanie regarding the database and some changes happening in 2020, and a quick update on the version 4.2 upgrade. So as many of you, I'm not sure if we sent out notification yet or not. If not, it will be coming out. AQO will be going virtual this year. We are canceling our in-person meeting, so it will be going virtual, which is a new experience for us all, and we are working through all of that. We will still have abstracts, and we will be doing poster presentations electronically, so it's kind of an exciting time. We've never done this before. We are going to be the second meeting for STS that is going virtual, so hopefully it will be a good show and we'll be able to get as much information out to everybody. We're still working out all of the details while we do that, so please be patient with us. We will communicate out details as soon as we're able to. And then regarding the adult cardiac version 4.20, it is still planned for July 1st. We do not plan to change that date. The hope is that with the decrease in the data collection and the way that the parent-child fields have been reworked, that it will decrease the amount of time spent for data collection, which will ease some of the data burden for you. And then we also do not want to overlap with the other upgrades. We did have an update to the version where we had a couple parent-child relationships that needed to be adjusted, so we had to come out with a version 4.20.2. Those new data collection forms, data specifications, and software specifications and other supporting documentation has been posted, along with an itemized checklist of the changes between 2.9 to 4.20.2 and between 4.20.1 and 4.20.2. So please check it out. And if we have time, I'll be happy to go to the website and show you where all that is posted. We are still working on the PROC ID chart, which will come out hopefully in the next couple weeks. DCRI is putting that together for us, and we are still working on the risk model variable chart, which will be released at the same time. Melinda is hard at work on the training manual, and that is expected to come out sometime in May, and worksheets are expected to be out in June. Just a quick note on the worksheets. The sites can customize their worksheets or make their own from the Word DCF that's posted online. So if you do not want to wait for us to come out with the STS version, or if you'd like to take it on yourself and come out with one along with working with your surgeons that might be more useful to them or get you what type of information you need, you can definitely do that just using the Word form that's already posted online. And I'm going to give a quick COVID update regarding the fields that we talked about adding last time, and provide some information on some of the questions we've seen come in so far, just to provide a little bit of clarity. These updates will be provided in the May training manual, but we were not able to get those in there for April since this was kind of an evolving situation. To clarify on coding no for the COVID-19 data collection form, you would code no for patients who are not tested, or for patients who are tested for COVID-19 and that test is negative. So to code no, it can be either of these: patients who are not tested, or patients who are tested for COVID-19 but that test is negative. And then you would code yes for patients who test positive for COVID-19, and the options, remember, were prior to hospitalization, in hospital prior to surgery, in hospital after surgery, or after discharge within 30 days of surgery. I have these on the next slide, so we'll go over those again. And then patients who reported that they tested positive for COVID-19 after discharge within 30 days of surgery can still be coded yes. Our STS surgeon leadership decided that that is still important, so we can track those and look at the outcomes. You have to verify that the patient was tested specific for COVID-19, and I'll get into that in just in 2 more slides, what that looks like. And then if the patient was tested within 30 days, but the results come back after 30 days, we would still code this as tested within 30 days. The patient was tested within 30 days. These results still are within that time period, even though they came out after the 30-day mark. So here, I just wanted to show some examples of, I had a couple sites email in what their vendor software looks like for collecting these temporary fields. So I just wanted to give a quick update as to what you may see in your vendor software. And this is just 2 examples. So we have quite a few vendors. Your software may look different, but hopefully it's still the same in thought. The yellow is what's in the STS data collection form. Code 10 for no, harvest code 11, 12, 13, and 14. The vendors have been asked to put these wordings in, but they're not required to change the harvest code wording. It's nice if they do that, but it's an option for them. They have these harvest codes in here. So this was one of the examples I have, and what this refers to, in the STS data collection form, we always have vendors build in 5 temporary fields. We've only ever used these fields, I think, 2 times maybe in the last 10 years is what I've been hearing. These fields that we add in, we have 2 yes or no temporary fields. We have a temporary date field, a temporary coded field, and a temporary text field. It's the temporary coded field that you're going to use. This field, they have specific specifications. So all of these other fields, that temporary code yes or no, temporary code number 2, date field, and text field, you just leave those blank, and all you do is fill in the harvest code, or if your vendor has already provided this verbiage, you would select that wording for that one field. And then down here is another example of what the vendor software looks like regarding the temporary fields, the temporary date field, and coded and text field. Again, we're just using this temporary field, this temp code. This isn't the sequence number for adult cardiac. It's a different database, but it's still the same short name temp code. And this is where you would fill in the answer for that. Hopefully that looks a little familiar to some folks. And then we've been getting asked questions about which type. There's multiple types of the coronavirus strand. The one that we're interested in, and the only one that should be collected in the STS database, is the SARS-CoV-2. This is the novel coronavirus that causes COVID-19. So this is the only one that we're looking for. If you have, if your test, these are other common types of coronaviruses, this HKU1, and these other 3, these are the most commonly tested. This is the one, however, this is the one we're looking for. So if your patient has a positive HKU1, that's not the same as COVID-19. We're looking for specific COVID-19 or SARS-CoV-2. That's the one we're looking for this field. And then we had some questions regarding cardiac rehab phase 2. Cardiac rehab phase 2 is the cardiac rehab that occurs outside of the hospital typically after the patient receives clearance from a cardiologist. And this is a type of monitored exercise program where they're hooked up to a heart monitor, and there's medical trained folks around who are watching people exercise to make sure they're not having chest pain or any other types of symptoms. This is just part of rehab that is intended to get the patients back to a higher performing level after they get cleared from their cardiologist. Phase 1 rehab happens in the hospital, so this is not the same as the cardiac rehab that occurs in the hospital. Patients usually are either discussed, phase 2 rehab is discussed prior to discharge, or there's a referral written that requires the cardiologist. Okay. In order to COJAS, this is going to be in addition to what's already in the training manual. In order to COJAS, you have to have some type of documented education regarding cardiac phase 2 programming. Even if your cardiac rehab program is closed right now, you still have to be able to document or show that you talk to the patient about the importance of cardiac rehab. This is really important to make sure that patients know that they're going to be continuing to exercise. If you can give them information for activities to be completed at home, you can COJAS for that. Documented advice on the importance of joining a phase 2 rehab program, even if your rehab program is currently closed, or documented advice given on the importance of joining a cardiac phase 2 program. You can code NA for a patient who had a documented advice given, but that patient is documented not to be a candidate for cardiac rehab phase 2 due to their elevated risk of COVID-19 exposure. If nobody talked to the patient about about cardiac phase 2 rehab, then you would code no. It's really important. We don't want the patients to go home and just sit there without any plan for exercising, especially after this major procedure. So cardiac rehab after surgery is extremely important, and we still encourage that. So if there's any questions, please submit them to the FAQ mailbox. This will be included in the training manual for May. Again, this is in addition to what's already in the training manual. So I would review that section, and we will provide some further clarity in the May update. All right, I'm going to hand it over to Melanie Bent for the Iqbia status update. Melanie?
Thank you, Carol. Hello, everyone. Let's go ahead and let's talk about status. Okay. Thank you. So the first couple of items that I'm going to cover will be related to the uploader current issues that have been reported. The primary two that have been raised and we're reviewing are related to reports of records being dropped during the upload process. And so we want to make sure that if you are experiencing this, please reach out to our support team. We're seeing that there are different scenarios that are causing this to happen, whether it's an invalid character that could be within one of the responses, but it seems as if the majority of what we're seeing is either invalid characters that are not that shouldn't be there. We are looking at ways to make sure that we can provide more feedback once the messages are being returned. If a record is being dropped, basically having the system giving the feedback of what exactly is occurring with that record drop. So that is in process. The other item that we are looking at that's been reported is related to the file structure errors. It's a generic message that comes up, and we understand that it doesn't really tell you specifically what is causing that file structure error. With that, again, make sure that you're reaching out to our support team so that we are able to review that file. But we are looking at ways to be able to enhance the solution, to be able to provide that feedback, to give you specific information to why the structure of the error, file structure error is generating. So that's in progress also. But I just wanted to really just reiterate that if you already saw or possibly seen on notifications, the issues that are being reported, that we want to make sure that you also contact support to report your specific issue, because there may be a difference. Okay, next slide. Okay, in regards to upcoming reviews of what's currently happening with the adult cardiac data quality report, we are currently reviewing and making corrections to some of the validations that have been raised. We are looking at trying to get those updated items and corrections in within the May timeframe. So each of the areas that you see here, for DQR, for the MBR, we have issues that have been raised in regards to the different variable data version variables that are appearing on maybe 2.9, and it shouldn't display on the 2.9. It should only display on 2.81, for example. So we're looking at making those corrections, and we're doing some updates to the layout to the actual report. So I'll talk about that a little bit later for the MBR. And then we do have areas within the dashboard with specific calculations that are not picking up certain case records. So in those instances, we do need you to report those items where you're seeing a discrepancy. Maybe a record is not appearing within the actual count. Some of those have been on a case-by-case basis where we had to review that actual case form record related to that calculation, but we have some general updates that need to occur, and we're working on those too. The actual STS JIRA IDs that have been provided to you. We are putting together a list of those, and once we have the actual updates and fixes deployed to the environment, we will make sure that the full list is available within the notification section. So that will, once those are available, we will make sure that the notification is updated, and you will see all of the areas and items that have been updated. Next slide. And so the enhancements that we're currently working on, for the uploader performance, we are implementing updates in regards to the processing speed for increasing the validation process with the at the time of upload. So if you had a file that potentially had, I'll say, maybe 1,000 records, potentially it could have taken, I would say, maybe 30 to 40 minutes. I've heard. I've actually had files that I've uploaded that's taken about 25 minutes. Well, that actually has been reduced with the changes that we'll be implementing. So the processing speed will be quicker during the time of upload. And then other enhancements that we're working on is related to the dashboard, where we do have users that have called in and said that there were missing specific variables. So just a reminder that when we initially launched the dashboard, we went with a specific set of data variables for each of the reports. And over time, what we will continue to do is add additional variables per STS guidance and make sure that those are included. And those would be existing variables. And then, of course, once we launch the 4.20.2, include those additional variables that should also display on the dashboard. So those would be additional enhancements. And then for the missing variable report, there will be some layout updates, and we will be including within the case list section of the report at the very bottom, where you will have an additional column for the short name. And so that will give you the ability to to sort on that column. And also I meant to also add, and this also should be on the DQR. I'm going to have to go back and look, but that short name column should already be there for the DQR. So you should have that additional column to be able to sort there. But we will be updating the MVR to include that column. And then there are some general updates for the layout that we will be doing for that report. And I think this may be the last slide. Let's just double check. I think it may be going into the support slide. Let's see.
So
yep.
That is.
All right. Well, thank you so much. Carol, did you want to take this one?
Yeah, I can run through this real quick. Thanks, Melanie. Thank you so much. And I'm sure I'll be calling on you shortly here with some of these questions that are coming in. This is just, thank you. This is just our support plan for Iqvia. We've gone over a few times, but I just like to remind everybody the phone number and email to use, and then how the questions are routed, and STS and DCRI will be answering questions that are related to us. So here's this is again, and then the resources again, the STS National Database webpage, the STS tech supported Iqvia, and the database feedback form, so we could hear what you like, what you don't like, or what types of improvements or things we may be able to improve upon to make your experience more, I guess, a positive experience. Okay. And then I'm going to go over to the questions and answers. Again, this is open discussion. Please use the Q&A function. We will get through as many questions as possible, and we encourage your feedback and we want to hear from you. So I'm going to get started here, and then first, again, thank you for joining today's webinar. The next adult cardiac webinars we have is April 30th for the version 4.20.2 webinar. We'll be picking up, I believe we just got through the operative section, so we're somewhere right around that area. And then the May 6th will be our monthly webinar. And I'm not sure what we're going to talk about yet on that one, but we will probably have an update from Iqvia, and I'll find something good to talk about and provide you information on regarding either the upgrade or current things that are going on in the database. and I'll communicate that out probably the day before about what that agenda will be. Oops. Okay, so I'm going to go over to the Q&A and we'll get started here. So the first question I think is going to be handed over to Jane Hahn, who's our Associate Director for Quality. This is the question, Jane. Is there an option for an individual surgeon just to public report his outcomes, or is it only just public reporting per facility as a whole?
Thank you, Carol. Thanks for your question, Jen. There currently is not an option for an individual surgeon to publicly report his or her outcomes.
Okay, great. Thank you.
Mm-hmm.
Next question. Do physicians have access to their outcomes via Iqbia or the dashboard? So currently the physicians will have access to exactly what you see now on the uploader side, that dashboard on the uploader side, which is the raw data. And then when we have the risk-adjusted and benchmarked outcomes dashboard available, they will have access to that. The ability to sort by their NPI or display their NPI in addition to the hospitals is a feature that is coming. And Melanie, did you want to touch on that any further?
That's it. So once you log in, just to give you the specific location, so once you log in under the operational reports, they will have access to see the current dashboard, as Carol says, and that's the raw data that's been uploaded. And then once we have the outcomes report available, the dashboard will be located in that same section underneath operational reports.
Perfect, thank you. I'm just going to go back here because I have a couple questions coming on. Okay, so for COVID testing, is it for the virus, the antibody, either or both? So the antibody testing is still being finalized in its development. I don't know that it's widely used yet, but what we're looking for is the virus, that the patient has tested positive for the virus, not the antibody. It has to be the virus, and it has to be specific to COVID-19. Next question. Has the training manual been updated regarding the 1/1/20 date to start capturing COVID-19 information, seeing as we do not need to go back and capture those retroactively? So we asked in our communication that we had provided in the last adult cardiac webinar and the email that had gone out regarding the capturing of the COVID-19 testing, sites can go back to January 1st, 2020 and fill in that information if it applies to their site. You are not required to do so. We ask that you would start with April 1st, that everybody will start collecting that data with the April 1st cases. However, if you have been affected or you choose to go back, you certainly can go back and capture starting on January 1st. Next question, is it still okay for us to collect the COVID-19 testing date? No, we aren't collecting the testing date. We're only collecting what the results, if that patient had a result, if that result was yes or no. So patients who were not tested or patients who tested negative, you would code no, and then the other yes answers are pretty much self-explanatory. We do not want the date or any of the other temporary fields. The only field we're capturing is this temp code 7230, sequence 7230 for version 4.29. From what date should we be collecting the COVID data? So again, starting with the April 1st cases, we would ask that everybody start collecting that field. You can go back as early as January 1st if you'd like. Our vendor put the COVID questions by the height and weight in the risk model section. Do we need to fill in both the vendor field and the temporary coded field, or can we just fill in the vendor field? So the vendor field should be this temporary code field. I would check with them to see what make sure that they use this temp code 7230. It may be listed twice in your vendor software if they duplicated it within the risk model field or risk section. So I would double check with them. I am redeployed and there's backup of IT projects allowed because of furlough, so the likelihood I'm going to get the new version downloaded by July 1st is not likely. Please reconsider the release. We don't need more stress. So the release is planned for 3 months from now, and I certainly understand the stress that's going on at some hospitals. This is our plan. We have to go forward right now as planned for July 1st, but I appreciate your feedback, and I'll take this back to our surgeon leaders. If the discharge summary or ABS after visit summary included CR, is that sufficient to code yes? So as long as there was discussion regarding cardiac rehab, phase 2 which happens after discharge, then that's sufficient to code yes. Melinda, are you there, and do you have anything to add to that?
No, I completely agree with what you just said. And having it on the discharge instructions for the patient, I'm assuming the nurse went over those instructions, and that including a discussion of cardiac rehab.
Great, thank you. And then next question is, so if a cardiac rehab referral is placed, will that qualify? Melinda, I would say yes to this as long as that cardiac referral isn't just for phase 1 in hospital, it's regarding outpatient cardiac rehab.
Correct.
Okay, thank you. Next question is the same regarding the vendor placing the question in the COVID question in the risk factor section, and then also the temp code field. Is it correct to do both? And I would only collect this field one time, and I would collect it where they put it in the risk section. I wouldn't collect this field 2 times. I would just collect it in the one spot, and I would ask your vendor just to make sure. I would reach out to your vendor just to make sure that that is what their intent was. Next question. I apologize I was late. Are there still plans to move the new form on the original date? And if so, what was the justification? Was there input from IT departments of your STS members instead of just data managers? We are not planning to change the date of July 1st. When will the Harvest 4 report be available in Iqvia? So Harvest 4 report was the report that came out from DCRI. That was data that was through September 30th, and that report should have been pulled down from DCRI prior to the portal closing on March 31st. So hopefully you pulled that down. They will be available from Iqbia, but it's going to be a while. They're in storage now, and Iqbia is not able to make those readily available to everybody. So that's why we've instructed sites to pull those reports down ahead of time. Does MVR stand for missing this variable report? MVR is the missing variable report, correct? Okay, next question. Melanie, this may be for you. Next question. I sent this to Iqbia, but want to reiterate here. We need to have the pre-op creatinine field included in the missingness summary as the field goes into the risk calculation on the risk analyzed cases. I haven't seen it on the dashboard.
Pre-op creatinine, I need to follow up on that. If it's not showing up on the dashboard, it may be because of the first batch of variables that were decided to go in the initial release. So that would be one that we would need to get guidance from STS to say we need to make sure to add that on the next iteration of updates. But let me go ahead and double check in regards to the missing variable report, because that should, if it's missing, and that's the thing, if the information is missing, then it should show up. But if you're saying that you're not seeing it and you definitely have examples of that not being populated and it's not showing up, we need to see. So Beth, if you're able to, if you have a ticket number that you're able to share, if you can put that in the chat so that I can look at the example that you had provided to support.
Great, thank you. And next question. My vendor is no longer going to be supporting the registry, therefore we will not be implementing the July update. What are the options for input and submission to stay current? So Christy, I do believe that we received your email, and we will be, we are having some internal discussions, and we will be reaching out to you and others who are in this situation. We will have further information for you in that email. So thanks for the question, and sorry that's happening. Next question. Please review the cardiac rehab again. We have standard orders for cardiac rehab post-discharge, but the program is closed. But they will contact the patient when it reopens. Does this meet the requirement for cardiac rehab ordered post-discharge? And I'm going to say yes. I would still code this as yes, since you discussed it with the patient, even though the facility is closed. Hopefully when that patient is ready to go to cardiac rehab in about, 6 to 8 weeks, that it's opened at that time. But I still think that this would be perfect to COGES, and I'm going to ask Melinda for her thoughts and confirmation on that if she agrees or has different thoughts on that.
Yes,
Melinda?
yeah, thanks, Carol. I think that if the patient there's been a discussion about it and the importance of it, and it's documented, then I think this is acceptable.
Perfect.
To code yes.
Thank you. Great, thank you. Next question, will Iqvia be doing the outcomes report every quarter the same as we were used to getting from Duke by procedure, all variables and outcomes? Thank you. So the PDF report is being transformed into a dashboard report, and you'll be able to download different types of reports from there for your quarterly report. It will be, that outcomes dashboard, benchmark dashboard will be updated quarterly. It will not be a PDF report. We will have more information. Iqvia is still building that, and we're still developing the bidirectional data exchange with DCRI. Once we have that and Iqvia has the data back from DCRI after the analysis, we'll have that benchmarked dashboard available to show you and give education on how to download and do the reports that you're used to. Melanie, do you have anything to add to that, or any timelines or?
We're still in process and working, and coordinating with DCRI in regards to the actual data exchange that we will be doing with them. So that's still in progress.
Great, thank you. Next question, has surgeons been added to the dashboard report? I'm not sure exactly what this is asking. We're not able to sort yet by NPI. That will be something that's coming in the future. They have been, surgeons do have access to the dashboard report. So I answered 2 questions. I'm not sure if I answered the one you were asking. If not, please provide clarity in the Q&A, and I'll get to it in a second. Will the antibiotic selection, timing, discontinuation be included on the dashboard soon? I think that one's for you, Melanie, and I'm not sure exactly. Do we currently show antibiotics on the raw dashboard?
I will go ahead and check, but if they're not seeing it at the moment, these would be variables for consideration to be added to the dashboard. So
Okay.
Let me go ahead and I can just take a quick peek and come back to that one.
Okay, thank you. Next question, which month was the COVID-19 documentation supposed to start? So you can start putting it in with your April 1st cases. However, some sites, especially on the West Coast and possibly New York, may have been affected as early as the last part of January. So that option is available for sites to go back and enter it at that time. However, STS is asking that starting with April 1st, you start entering that information on your cases. Year-end 2019 reports. Do you have an idea when they will be released? So typically the Harvest 1 2020 reports, which is data through December 31st, is released the end of April. Because of the bidirectional data exchange with the DCRI and Iqvia, there's probably going to be released in mid-May. I don't have an exact date yet, so we will update the Harvest page with that information as soon as we have it and communicate out to sites as we get closer to the end of April and have a better idea of when those reports will be available. Will DCRI continue to provide the full analysis report? So again, those PDF reports are being transformed into the benchmarked dashboards, and the data is coming back analyzed from DCRI. It's not going to be the same PDF that you've been used to. Next question, are we to code all adult STS cases COVID-19 starting January 1st? So I think I did answer that question, and hopefully it's clear. You can go back to January 1st, however, you do not have to. We ask that you start with April 1st cases. I'm not going to answer questions on the dates any longer. That will be the last one. So start with April 1st should be entered in for all cases starting on April 1st. You have the option to go back to January 1st to submit if you'd like. Are you aware that many hospitals have put a halt on major upgrades during this pandemic? This will severely hamper the vendor's ability to deliver version 4.20 and 2 in a timely manner. Thanks, Noel. So most some hospitals have put halts on IT, and this is 3 months away. So hopefully by the time we're ready to do that and all of this, hopefully we have some ability to get this implemented in July 1st. So I appreciate the feedback, and we'll take it back to surgeon leadership. I am aware that most sites are on a cloud-based system with their vendor software, and it doesn't require much IT involvement. But again, we will take this back, and we don't know everything that happens at sites. We have had communication from folks, but we'll take this back. The main point is that we want to decrease the data burden at sites, and we don't want to go live with 2 versions at the same time, which will be very stressful for sites in January when we're playing catch up from all of this downtime. So we're aware of it. We just have to make the best decision, including what the future looks for other upgrades. Next question. Our hospital is in Suffolk County, New York. We are in the midst of the COVID crisis. We are a large majority of our nursing staffs are redeployed to other areas. It will be extremely difficult. So I hear you with the upgrade on July 1st, but hopefully, we have had discussions about it. The surgeon leadership is very aware of the situations that are going on at hospitals. A lot of our surgeons are on the East Coast and have strongly said that we really need to go live on July 1st because of the decreased data burden. But I will take your feedback back. I appreciate that. Next question. Is there a report with surgeon-specific outcomes? So there is a surgeon-specific outcome report. And Jane, if you're still there and you're hearing me, do you want to take this regarding the surgeon-specific outcome report?
Sure, I'll give you a little break, Carol. You've answered about 20 questions in a row, so my pleasure to help. Yes, there is a surgeon-specific composite report available. There is an election form that each of the surgeons requesting that report will need to complete. It's web-based, and there's a PDF option as well. I will place a link in the chat box here so that you can all see it. Please note that the email address that's provided on the election form must be that of the surgeon. We've had several election forms come in recently where data managers' emails are provided, and we are unable at STS to share this report with other folks other than the surgeon themselves. So if you wouldn't mind just communicating that to your surgeons, that would be great. And if you just give me 1 second, I will go ahead and put that election form link in the chat box for you.
Perfect. Thanks, Jane.
You bet. Thank you.
Next question. Can we see risk-adjusted outcomes before the final report is published? So the risk-adjusted outcomes are available because of all the data that goes into the analysis, and then those risk-adjusted outcomes are calculated, and then that final report comes out, or the final data comes out that will now be displayed on your benchmarks dashboards. So you can see it before it's published. It all gets kind of pushed out at the same time. I hope, Michelle, if I didn't answer your question, please provide some clarity in the Q&A. Next question. As data managers, it may be nice to have a preview of what the surgeons see. So we will be doing education on what the benchmark dashboard looks like, and I have asked that we also do surgeon education, have a webinar for just the surgeons to talk about what their dashboards are going to look like. It will be the same as what the data manager sees. They have similar access to those dashboards. They just don't have the uploading capability for submitting data. So the surgeon's dashboard will look similar to what the data manager's dashboard will look exactly the same as the data manager's dashboards, and we'll do education for both the data managers and the surgeons prior to it becoming, the data manager prior to it becoming live, and the surgeons maybe afterwards. Definitely understand the importance of the data managers knowing what the surgeons will have, because you will be fielding most of their questions. If a patient has a positive COVID test and expired, how will the COVID results affect our reports? We're not quite sure yet. We still need to get that data in. That's why it's important to make sure you abstract those fields. And once we have enough data, we'll be able to analyze it and see how we best will move forward with that knowledge of what we get from the outcomes and those COVID-19 patients. Will decreased COVID-19 patients be risk adjusted in any way not to offend benchmark procedures in any of the databases? Not quite sure yet. We need to get that data in to analyze it to make those decisions. What was the date of the May adult cardiac webinar? I know it's at 2 p.m., but I didn't catch the date. I'll put it back up on the screen. Let's see. May 6th is the next adult cardiac monthly webinar. That's at 2 p.m. April 30th is the version upgrade webinar. Next question. For dashboard, is version 2.81 specific dashboard display available or coming? At this point, I look mostly at mortality fields, and at least for these dashboards, only display version 2.9 data options, even when I filter for a date range that includes 2.81. So it ends up showing mostly missing data. It should show, and Melanie, you may want to take this one, but I believe if they filter on the dates that contain 2.81, it should be displaying the 2.81.
Yeah, so it sounds like you may be seeing something that, and I'm not sure if you've already reported that to our support team. I think it was Darlene that was listed on that question. But we would need to take a look at what is displaying. So you should be able to see the 2.81 related variables with those counts. So we may need to just take a look and see what's occurring.
Perfect, thank you. Okay, next question. What if the patient tests negative for COVID, but physicians feel it's highly suspicious for a false negative and is treated for COVID? How do we code this? You have to have a COVID-19 specific test, and that test has to be positive. Physicians are thinking that they have COVID is not enough to code that as positive. You have to have, or code that field as yes. You have to have a COVID-19 specific test, and that test has to be positive. You would code no for these patients if they do not have that specific test for COVID-19 and that test is not positive. If you don't answer the COVID question, is that to be taken as a no? Yep, correct. So the missing data, usually what happens in the databases is missing fields. Usually if they default to anything instead of missing, it will default to the lowest risk. So this, in this case, it would default to a no. It's really helpful, though, if you're able to provide that field instead of leaving it blank, because we'll be able to use your data and analysis to look at how outcomes are affected related to COVID, and having negative is just as important as having positive testing. Audio is frequently cutting out. Are you all hearing me okay, or am I cutting out?
No, I can hear you. Can you hear me?
I don't know if I can hear you fine, yeah. I don't know if you're joining from the web, but you may want to rejoin. It looks like other folks are hearing me okay too. You may want to rejoin the audio either via a phone or from the web and see if that helps. Is there a date for release for the Harvest One report? Hopefully soon, and we will communicate that out. It should be probably sometime in May is what we're aiming for. I will make sure that that's communicated out when we have confirmation and we get closer. Next question, when will the entire 2019, okay, just answered that question. The STS discussed the move to the new form with members' IT departments to see if they had resources available. All right, so thank you for the feedback. We also will not have software as 7.120. What do we need to do with STS and Iqvia? Donna, if you could just email stsdb@sts.org, we'll be able to provide you some further instructions on that. Next question, for cardiac rehab 2 with the COVID-19, does this start with April 1 cases? No, I would say that if you have a COVID positive patient, or I would say, I'm sorry, this doesn't refer to the COVID positive patients. For cardiac 2 rehab, I would say, and Melinda, you want to jump in here, but when do you want to go back with this? We can probably include a date. I know we said April 1st.
Well, I think if the documentation's in the chart, since this is an unusual situation and we weren't able to get this out with the April updates. The April updates. I'm thinking for sure for April, and for sites that might have been affected prior to that, it seems to me reasonable that it could go back even to March. There's certainly some areas of the country that were greatly affected even during that time. But that's totally up to you, Carol. I know it kind of goes against what we say about using the training manual for the surgery date but this is an unusual situation.
Yeah, and I think the only difference here is that, well, what still remains is that we need to be discussing cardiac rehab with our patients. Regardless of what's going on with COVID-19, it still needs to be discussed with the patients, and that's how you code yes. So I think we can put this in for April. I'm not sure. The only one that would be really affected is the code, the NA. And for that, I say we can go back to even, January or February cases, because that is, we should probably take this offline and discuss it and provide clarity, Melinda. But I would say that those are the patients that are going to be the ones not going to cardiac rehab because they're at increased risk 8 weeks after, which would put them into the March timeframe for starting cardiac rehab too. So I would say that those, January, February cases would probably be the most likely to be coding this NA field if we make that applicable at that time. But how about you and I take this back and we talk about it offline and come up with some clarity for the May training manual as to when we can start using this field. I think that would be fair.
Yeah, I think that sounds great.
Okay, instead of making a decision on the fly with it. Great question, Jennifer. Next question. Next question, if a patient is readmitted with COVID and the patient is beyond the 30 days of surgery, but within the 30 days of discharge, is there a way we capture that? Will it be added to the readmission reason? Well, you're not going to be capturing your 30 days of readmission if the patient was past 30 days of surgery, so this wouldn't even be captured as a readmission. You will not capture this for the COVID field. It's out of that 30-day range post-OR date. However, if that testing occurred within those 30 days post-OR date, that is something that you can capture. So Joy, if you have a more specific question on that, or if you have an instance where that has occurred, you can submit it into the FAQ mailbox. And Melinda and I can talk about it. And then Beth has commented, within 30 days of surgery, it does count. I'm sorry, within 30 days of discharge, it does count. No, it's 30 days of surgery. I'll go back here. Yes, after discharge within 30 days of surgery. Not within 30 days of discharge. Everything is within the surgery date. What about the star readings? Will they still come out semi-annually? Yes, the star readings will still be updated twice a year for adult cardiac. And then Melanie, it looks like Beth has provided her ticket numbers for you.
Okay. And it looks like there was a response. Okay.
Yeah.
And this is in regards to the additions that are, last creatinine. Okay. Yeah, but I am not seeing that on the dashboard. So we would just need to just go through, of course, all of the variables that need to be added to the dashboard. But we still need to, I guess, look into the other report, because that if you do have examples of case forms where the information was indeed missing, that variable should show up on the missing variable report. If you're not seeing it on the missing variable report, is you have data that's populated in there. So just want to make sure that if you're also referring to the missing variable report, that's how that functionality would work. Okay.
All right, great, thank you.
Thanks.
Just to clarify, we code no if a patient was not tested or had negative COVID-19. We do not leave it blank. Correct, just code it no. Those cases get coded as no. When do you think you'll be done with a finished dashboard? So again, that timing is probably sometime in May. We will communicate that out. That's not a finished dashboard, it's a different, that's the benchmarked dashboard. Next question, for the documentation for cardiac rehab, does it have to be from a provider, APP, or could the education be documented by nursing? It can be documented by nursing. Sometimes this is even documented by the in-hospital cardiac rehab team or physical therapy. Any follow-up on that, Melinda?
No, I'm sorry, I couldn't find my mute button. No, you're correct.
That's okay.
Correct. It can be nursing or other personnel.
That's okay. Next question, is the surgeon associated with the procedure identification and the operative portion of the dashboard? The surgeon's MPI are not associated with procedure identification. I have a question regarding older posted DCRI reports. Who do I contact for help? I contacted STS and ACC, but have not had a response from the ACC. I'm not sure why you would contact ACC for the STS reports, but if you would like to send in an email to me, you certainly can, and I can try to get you in the right spot here. Hold on one second. I'll get you my email address up. Oh, I don't have it on there. Oh, there it is at the bottom of the screen. I would like to follow up. So Melanie, there's another ticket number for you.
Okay, and we have members of our support team on also, so I'm asking them to also take a look at that specific ID.
Thank you. If we do not renew our vendor in July, would I be abstracting data for the entering it directly on an Iqvia provided form? So there will be a way to do direct data entry, which is planned to start in July. We will be providing more information on that as we get closer to that day. Not a question, just letting you know our facility will not do upgrade, no IT involvement related to COVID-19. So for 4.2 upgrade is our facility is out for our facility in July. So this is 3 months away, and I know everything is going on right now. It's causing a lot of dismay at sites and a lot of angst within the community about doing upgrades and things like that. It is 3 months away. Our intended target date of July is 3 months away. So just please be patient and let's see how this plays out. If we are able to do any types of changes, we will let you know. We're fairly strong on the July 1st date, but if we are able to make any type of concession for that, we certainly will. We have to weigh everything that's going on right now. And when we polled everybody in the last call, and it was probably about the size of a group, half of the people who responded, over half of the people who responded were still strong with the July 1st date. And it may impact other sites who have a general thoracic update planned for January. And doing 2 updates, as you could imagine, with major changes in both databases will be quite time consuming for a site. So we are, even though this might be a quick fix for right now, we have to consider every possibility and the impact of all of our choices for now and for the future. So even though it's simple to make that discussion, please just be patient with us. And it says the people who responded were not in the IT department. I understand that IT folks may not have been on that call, and they may have been on the call. We don't know that. So I appreciate the response to that, Jay, but we don't know who all was and was not and what roles they had. So thank you for the feedback. Has it been determined if COVID positive cases can be included in our outcomes? No, we need to get the data in before we make those decisions. Is there any way we can get the updated training manual before the end of May? Sites need to have enough time to educate staff for the new version, and 1 month is not enough time. So that's why we've been doing monthly webinar calls on the upgrade since January. Hopefully you've been joining those. If you have not, please review them and please share them with your staff. Thank you. Is Iqvia going to provide a slide presentation like the STS used to provide? This was very popular for a quick look by all. Please consider doing this. And Pat, I'm not sure what type of slide presentation you're talking about, but if you could provide some more information, that'd be helpful. It's not the decrease in data burden that's problematic for the upgrade, but rather the issue involved with site IT department saying, no, we can't move forward with anything in this COVID crisis. So we don't know if we're still going to be in a COVID crisis come a month from now. We certainly understand the stress that everybody's under, and everybody, whenever we're under stress and we have change coming, it's never good, it's never received well. So I would just let the surgeon leadership make the decision with your input. It's helpful. So I appreciate it. We have to consider everything that is going on. And I think that's the last question I'm going to take with that. Next question. There's a 30% false negative on the COVID test currently in use. Just thought I would share. Correct. Thank you. My dashboard is the smallest section on my screen. Am I doing something wrong? I think there's a way to make it the full screen, right?
There
Melanie?
is. Yes, there is. So if you're looking at your dashboard, you will see at the bottom left corner where it says ACSD Participant Dashboard Report, it's a tab. If you right-click on that tab, it will give you an option to open the page in a new window, and that will resize and open up in a new tab and basically make it much bigger for you. So try that out and you can see. And I believe we did training in one of the webinars where I actually showed that. That probably was either November or December.
Great, thank you. Next question, the surgeon-specific consent form needs to be filled out yearly or just a one-time thing? And Jane, are you there? Did you want to take this one?
I am here. It's just a one-time thing.
And then they can rescind it anytime?
They can, absolutely.
Great, thank you.
Sure.
Can we submit monthly data to Iqvia like we should do with DCRI? You can submit daily. You could submit multiple times a day. You can submit monthly if that's your process. So absolutely. I just reviewed, and the vendor that has the COVID testing under risk factors is not listing the code 7230 when looking at the shortcuts tab for the code number. Does this indicate that it is best to use the temp code field and not the vendor created field? I would reach out to your vendor and ask them what their intent was and how that's being mapped, if that's being mapped to the field temp code sequence number 7230. Readmission is from discharge date. Yeah, so readmission is from discharge date, but the poor outcomes are not from discharge date. They're from within the 30 days following surgery or within that hospitalization. Per the training manual, readmission if coded yes, right. So readmission is within 30 days of surgery, but for the post-operative complications, that is within 30 days of surgery. We have an export issue and a ticket number from prior. So I'm going to leave that there for you, Melanie and team. I'll move that over to the answered questions. And I think that we have time for one more question. Is the definition for readmission changing? Currently, it is indicated if the patient was readmitted within 30 days of discharge and not from surgery date. No, the readmission is within 30 days of discharge, but what I was referring to is the complications after surgery is always within the 30 days of the OR date or during that hospitalization if it's greater than 30 days. Any decision on postponing, okay, last question. Any decision on postponing STS audits for this transitional time period in crisis? STS leadership is talking about the audits for 2020, and we will be communicating out any changes as soon as we can. Oh, I can take this one too. Do you know of a TVT upgrade coming in June or July of this year? And not that I'm aware of for this year. So I appreciate the question, but no, I believe that if there's any changes to TVT, the last I heard from our TVT group was that it will probably not be this year. So they are still working on that with their new platform. Okay, I guess that's it. So thank you, Melanie and Jane and everybody for joining, Melinda. And I hope you all stay safe and we will talk soon. So take care. Let's see, I'll put up the next dates for you here. Oopsie, April 30th. Talk again, and I think we're going to be in the operative section or somewhere right around there. All right, take care, everybody, and stay safe.